Well, welcome and thank you for taking, they can't hear me, by the way, they can hear you, so you'll have to repeat the question. Um, well, thank you for taking time out of your busy schedule to be with us. Could you just state your name and your affiliation?
My name is Elizabeth Montgomery, and I am the Senior Project Director for the Primary Care Initiative at the National Kidney Foundation.
Okay. What drew you to this event? How did you first learn about it?
I learned about this from one of my colleagues in our affiliate office in Philadelphia. As the individual who is the architect of the Primary Care Initiative at the NKF, I am always looking to identify organizations and individuals who are on the same path that we are on, to try to create a framework of collaboration, knowledge sharing, and things of that nature. So when I saw that the organization here was further along the value stream than many other organizations, I made the decision to come down here. And it was really quite interesting because several weeks ago we had a conversation with Cerner Logic, which is their analytics team. And Christiana's name actually came up in that conversation with Cerner as one of the organizations that is further along the curve in CKD. And then 2 weeks later, out of left field, came the invitation to attend here. So here I am.
All right. Well, that's great. So you've been participating in the conference. What sticks out? What resonates, or what has resonated thus far? It's a general question I ask.
Yeah, I think.
What did you learn that you didn't know?
How sophisticated the system here is in the state of Delaware. That certainly for me was.
Repeat the question.
Blonde moment. Sorry. So what did I learn when I came here that I didn't know? And my first answer would be the sophistication of the system in Delaware in terms of the activities that are actually going on at a statewide level to address this significant public health problem. The second thing that I learned was that there are some relationships that the National Kidney Foundation needs to build with some of the individuals who have presented today, because it's very clear that the team here is further along the curve than many other institutions. So it was very helpful to identify people that we might be able to engage in some of the initiatives that we're creating.
Okay. And are you planning on participating in any of the workshops?
I am planning on participating in the workshop. I'm not sure which one I am in. I am very interested in trying to bring the perspective of early diagnosis into this conversation. That the conference thus far has talked about improving care for people who are identified. If you look at the statistics, almost 90% of people with chronic kidney disease are not identified in primary care. That diagnosis is a proxy for severity, so that the opportunity to intervene and to make any positive change is absolutely lost with patients who are crashing into dialysis. So if there's any way to influence the conversation around the nature of the system that's created, the analytics that are actually driven, and the translation of that into some sort of dashboard or feedback that will close the loop with primary care, that will allow primary care clinicians to get ahead of CKD instead of responding to fully progressed CKD. Those would be the questions I would love to insert into the dialogue here.
Well, are there aspects of a registry that you think could contribute to that? Because I think one of the goals we have is to try to get a better sense of the full spectrum early, or we could say new, really early stage kidney disease patients. Obviously we're using the word chronic kidney disease, but there is an intention. What happens before that if we get lucky and can find it through some appropriate surveillance regime. What do you have any thoughts about what that registry should contain?
Oh,
Not to be too nuanced, but just in general.
okay. Do I, or does the National Kidney Foundation have any thoughts about what a CKD registry should contain? I have two aspects to answer that question. So, in the work that I've been doing, I've had the privilege of interfacing with a variety of different stakeholder groups in CKD. Payer groups, health networks, individual clinicians, large employers. And the underlying truth is that CKD is a very simple diagnosis. It's 2 inexpensive laboratory tests. One of these tests is part of what's known as a basic metabolic panel. So most people will have information regarding their kidney health in their medical records simply because it's calculated out of every basic metabolic panel that's run. The challenging part is not that the information about these tests can't be captured, although data interoperability is a significant problem. So creating a registry where you have the information regarding the 2 tests captured in a consistent way, where the measures of reporting are consistent from laboratory to laboratory, would make a tremendous impact on the ability to identify people with CKD. The National Kidney Foundation is working with a large Blue Cross Blue Shield plan in the region nearby. They had 3.8 million lives and very sophisticated predictive analytics. They were not incorporating these 2 tests into those analytic profiles. And when we sat down with them and worked to add even those 2 factors to the conversation, 155,000 people were identified overnight. So just being able to extract that data would be meaningful. But the bigger challenge that we have to face is one of this translational research conversation, where at the moment today, if you looked at undiagnosed chronic kidney disease in a primary care population, and there's a study that was published in November of 2014 that I'm speaking to, the ADD-CKD study. In that study involving patients with diabetes, which is a significant risk factor for CKD, 80% of the people with undiagnosed CKD in the primary care population had the information in their medical records that illustrated that their kidneys were already impaired. So this is as much a question of, yes, we have to get the information there, but there's the second piece of how do we translate that information into a framework so that that information is recognized for the impact that it has, and that chronic kidney disease is recognized for the underlying contribution it will make to downstream negative cardiovascular outcomes.
Yeah, the term of art that we use here in our early warning system work is afferent and efferent arms, where you have very good sensory detection pieces, yes, but it has to have a strong connection with the efferent piece.
Yes.
And your whole policy apparatus and policy described as an institutional prescriptive actions that are aligned with the threat assessment.
Yes, absolutely.
If the threat increases, then you want to remove choice and say these things must happen.
Yes.
Well, that's great. So, is there anything else you would like to mention that you have maybe have not been asked?
I think the single most important aspect to CKD from my perspective, the question is, see, I do learn occasionally. The question is there anything that I would like to mention that I haven't been asked? And I think from my perspective, the most important conversation that we can have is about changing the relevance of chronic kidney disease in terms of where it fits in a chronic care model. that at the moment, as many of the presenters at the conference have indicated, that it sort of is an afterthought in the discussion and only elevates to a level of priority when we move in the direction of really poor outcomes and tremendous cost. So we've been framing this conversation about CKD in a population health model as having CKD as the canary in the coal mine. That when you think about chronic care management in a population with multiple comorbidities, if you identify underlying chronic kidney disease, you will have identified some of the most vulnerable and expensive patients in a population. So any investment that can be made to reduce progression and preserve, kidney health will have significant downstream positive impacts on a number of different levels, not the least of which is cardiovascular outcomes.
All right. Well, thank you.
Thank you.
Was there anything you wanted to add? I think we're good. Was there anything you wanted to add?
I think she did good.
Okay.
Thank you. There's hope for me.